You feel your heart beating. You're so smart. Tell me you nurse students without telling me. My dad was something that said, somewhere in the streets like Lexus. I don't know who you think I am, but I ain't in nurse school. What are you talking about? My bad, honey. Then I was telling my auntie about her cholesterol. She went to go get her cholesterol. I ain't gonna die, am I? I said, well, auntie, I ain't no doctor. And I ain't a nurse yet, but I do know enough. She was like, you so smart. Everything you tell me is what my doctor told me. My doctor told me all that. She said, I know you know what you're talking about. Let's get doctor. And she on a tour of the state. The medicine we did, I said, yeah, they probably got you on one. She said, how you know what medicine I take? I said, I didn't know. That's the only thing Doc knows. When you go to nurse school, everybody think you're a nurse already. They fancy. So they be asking you questions. I'm like, what the YouTube be? How to be on YouTube? I'm not a medical professional. Please do this at your own discretion. It's how you do it at your own discretion. Yeah, because I'm not responsible for that.
Yeah, we met him at the hotel. Really sweet. He's from the DR, lives in Spain. He's from the DR, lives in Spain, but now he's in Hilton Head for work.
That's what I said.
When I tell you, I can figure out his accent is like light.
I think I could use it.
I need to go get my little song out the car.
What?
Right, I already have mine. Well, I took the top out, just the bottom.
You always run out. I guess you always steam iron them.
Okay.
Just
Just a little bit.
nice.
What?
What'd you do for your
Because you know, twists get old quick. And I ain't put no beads on them, so you know they can't.
What's that? They break the top and then they start twisting the bottom.
Yeah, and see that's the thing, and one of the top is the bottom. Because you know their hair real fine, so start to unravel at the bottom. No, I should have put the beads on and it would stay there long.
Literally?
But
All of them in the car seat.
I would have
I got the movies and I was like, you got that because
I would have died.
I did. Literally, I like took them out, put them in the pillow. Yeah, hold out that
That's one way to end the argument. I feel like I would hold that every time we argue now, like in the just be like, "You're marry me." Gonna marry me. Just end it like right there, and that will end the whole.
Yes. But he's walking his little cliff thing. Oh my gosh. He did it. I was like,
I about cried when I upgraded. I think
there's this whole of like I don't understand it. Okay. There's like etiquette with like and rules for this person is you have to wait a certain amount of time to see if anybody else wants your character. And you're like waiting to be smaller, so you can't do it.
I've been getting this speech hard. And then only like 5 but always
Which seems like I know what he did.
so it's not 75.
It now,
Yeah, lesson level 1 will be a 75, level 1's 80, level 2 is 70.
Pretty serious. And so that's the first part.
Not in the past year with me. I don't know about previously.
Sure. Level 2 to match. Yeah.
I'm just trying to figure out what
Yeah.
And he's like in his like caption, it
All right, good morning, everybody. We are going to get started in just a second. Union and Sumter, you guys are okay to start whenever your faculty are ready for proctoring your exam. We will resume class at 10:40, so I'm going to go ahead and mute myself so that way I don't interrupt anybody over there. Yes, I'll check your records.
Do you want our drug cards now?
Yes, if you have to turn in drug cards or ATI remediation and you didn't already turn it in online, go ahead and bring that up to me real quick before we get started.
Oh, that's good.
Yeah, I saw yours already. You're good. Thank you. Okay.
We're the one that for yesterday. You're the one that for yesterday that I like. Oh, I didn't have time this morning.
Oh, no, what's it called?
I will go look. I checked them at like 8 or so this morning, so if you submitted it after that, I haven't seen it yet.
Just like I'm good. No, after the I'm sorry.
Yeah, I have 2 questions I'm going to go over that less than 75 minutes.
But I had shorts, but I was like, no, this look cool.
I don't want to see that. I would not like to see your butt.
I didn't have time to go any.
All right. I will go ahead and pass out your scratch paper.
It's like you do, like you do out here. You know how it's doing. It's like you was anticipating. I was trying not to do it. I feel like I should actually know about this creative bit.
Professor Nobles, can you hear us? Is there paper? Do we give paper for this exam? For this exam?
Yes, we do give paper.
Okay, thank you.
Yeah, thanks.
Oh, yeah, yeah. Bro,
It really takes 15 minutes to walk out of there.
So, I was like, it's very obvious. He's like,
Are in
Should we have scratch paper?
Yes, it's proper. What?
Is
that
that
the
Taylor's
remediation?
whistle?
Yes, the remediation.
So, is this the, like, is this one if we get like a section under 65, or do we do all of them?
All of them.
Oh, okay.
Yeah, I know that's not the answer that you wanted.
Never mind.
Yeah, so I went ahead and put in grades for the proctored ATI. Obviously, again, keep in mind if you don't do your remediation, you'll get a 0. But I went ahead and put in the grades so you can see how it affects your grade. Y'all, don't sweat this one too much. Don't let this like bruise your ego or anything if it wasn't that good. Because again, we're very early on in the program. We haven't had a lot of we haven't even finished content, right? Especially at the summer, we're at a significant disadvantage. But in general, that's why the pharmacology ATI exam is only worth 2%, whereas I know in all of your other classes it's worth 8%. It's because there's just so many meds that we cannot cover everything in this one class. So even if you made the lowest possible score, as long as you showed up to take the exam and you do the remediation, it's only going to have an effect of half of a point on your final grade, okay? So that's why it's designed that way. So don't sweat it too much. Don't forget that you do have to do your remediation, right? So that's going to be due 6/26. It's our last day of class. Well, not really day of class, but that's the day of our final exam. I did just open up on Blackboard under, where did I put it? I think I put it under week 6 after class. If you want to turn yours in digitally like you did with the practice, that's fine. Just remember, it does have to be handwritten, but just scan it in or whatever. I put in an ATI proctored remediation turn in. So you can turn it in that way, or you can bring it to the exam and turn it in, and I'll give it back to you after the exam. Yes.
Also, do you want like one remediation for like each one missed, or do you want like sections? Does that make sense?
Each thing should get, like, you know how like in the focus assessment it tells you which template every single, when you go in your focus review it'll tell you exactly what template you gotta do for each item. Does that make sense?
Okay. So if I missed 4, then I do 4.
However many things the focus review tells you to do. So it should like say like for this question there might be like 4 things for one question. Sometimes there can be.
But that all can go on one sheet, or no?
If it's different templates, it's got to be on the different templates.
Okay.
If it's the only one template, then it can all go on one template. Yeah. Any other questions about the ATI remediation? Okay. It's over. It's done with. We can not think about ATI. Don't wait till the last minute, though, with the remediations because they're a little bit brutal. So I would recommend maybe doing a couple each day so that way it doesn't all pile up on you, especially while you're trying to study for exam 3 next week and our final exam the following week, okay? Okay. So...
I'd have to make
we're going to go over a couple things from quiz 4. So quiz 4, overall, the class average was pretty good. Y'all had an average of 92.6. It took you about 15 minutes or so to take this one. There were 2 questions that less than 75% of the class got correct. Hang on one second. I just need to record this so I don't forget. Okay. And so we're going to go over those 2 questions, and I think a couple people approached me at the beginning of class saying, like, we have some questions about these quiz questions, and I think that this will clear it up. But if you have additional questions about what you saw in your quiz, I'm happy to answer those now as well. But we'll go over these first. So both of them were select all that apply questions. The first one is the nurse is preparing a teaching plan on the administration of NPH insulin, or Humulin N, for a newly diagnosed type 1 diabetic client. Which action should the nurse include in the plan to promote safe administration of NPH insulin? Select all that apply. So, what do you guys think this one is? B. C.
D.
Not D. It's B, C, and E. So I think most people recognize that it's NPH, right? That one should be cloudy. That's the only one that should be cloudy because it's a suspension, right? So not a lot of people put A. I think some people didn't select E. So remember, when we have a suspension, it's not a fully dissolved solution like our other insulin. So you do want to kind of gently mix or agitate the vial to mix it up. But D is not a correct one. So it doesn't have to be stored in the refrigerator. After each use, unopened insulin goes in the refrigerator. After each use, it's fine to be at room temperature. Some facilities do store theirs in the fridge, but it does not have to be stored in the fridge. And then the next one, a type 1 diabetic client prescribed regular insulin 3 times daily. In addition, they also take propranolol or Inderal, right, a beta blocker. What are the risks when combining the 2 medications? Select all that apply. So A, the effect of insulin is reduced by the propranolol, yes or no?
No.
No, right. The opposite's true. The effect of insulin is actually increased by the propranolol because of the beta 2 antagonist. Okay, B, there's increased risk for hypoglycemia due to a decrease in glycogenesis. Yes, absolutely. C, symptoms of hypoglycemia such as tachycardia will be masked.
Yes.
Yes, it's a beta blocker, has cardiac effects. Perfect. D, gluconeogenesis will occur and cause further increase in blood glucose levels.
No.
Correct, false. And then E, symptoms such as confusion caused by the lack of glucose will be masked.
No.
No, right? So it does mask our hypoglycemia symptoms of like tachycardia, palpitations, sweating, right? But not confusion. It doesn't do anything with the brain.
So the specific those
Yes. Yes. Does that clear up things from the quiz if anybody had questions? Yes.
I have a question, but it's a different question.
Okay, what's the question?
It says the nurse is reviewing the medication history of a client who has type 2 diabetes. Which finding would be a contraindication for the administration of Actos? So when I was reading in the book, I remember, I chose the right answer, but I'm like a little confused. So when I was reading in the book, it says that like it's a contraindication, like because it causes it can cause fluid retention. But then it also said it was a contraindication in patients who have like cholesterol problems. And I know one of the answer choices was stating that a client who has hyperlipidemia. And I was just confused with the hyper. Like, could that also be an answer choice? Maybe just not the answer choice?
Yeah, let me pull up that question to look at it. Hang tight one sec. Okay, let's see. I'm also going to see if anybody else missed it because I am willing, if you can like show me where it says it in the book, I'm willing to adjust. I don't think I had included it on my slides per se about the hyperlipidemia, but that's not to say that it's not true. It just wasn't one of those really important things that I picked out. So if you saw it in the book, I mean, the book is not wrong. Let me just pull up the whole quiz and make sure that we didn't have people putting the other answer, because if so, I want to give credit if that's the case.
Did we? I don't really remember us going over. I remember where it is, but did we really go over it? I could go back in your lecture and listen to it.
Honestly, girl, that was a blur of a day. I don't remember. I'm pretty sure it was on the slides, but I could be wrong. I definitely could be wrong. But remember, anything is technically fair game from the book versus, yeah. Okay, let's see. Let's see. What was the start of the question again? Sorry.
Nurse is reviewing the medical history of a client who has type 2 diabetes. And it's talking about the medication Actos.
Okay. Okay, here we go.
And I got it right. I was just like...
Oh, yeah, everybody got it right, so
Okay,
I won't adjust it.
Okay.
Yeah, but good question. Yeah, if it did say that in the book, then yes, that is true.
Okay.
I will change the question for future so it's not confusing. Thanks for bringing that to my attention. Okay. Any other quiz questions?
I have a question about remediation. Can we, if we like have an iPad, can we just like write it on that like we do the drug cards, or do you want them?
That's fine, if that's how you like to do it. Yep, I'm okay with that. All right. So let's turn this back on. Okay. So that is it for the quiz review. So moving forward in the class, this is where we are, right? Today we're going to cover our antimicrobial drugs, which is going to be like our antibiotics, antifungals, antivirals, primarily antibiotics. You'll have quiz 5, sorry. I just opened that up this morning, so that will be due by next Monday at 9 a.m. this is your last week of drug cards to do, so those will be due next week. Exam 3 will be next week, and then the following week we have our final exam. So this is our last day of content. After we do the antibiotics and antimicrobial drugs, we'll cover some GI drugs, but I'm hoping this isn't too overwhelming today. The antibiotics are a little bit stressful because there's a lot of them, but I'm going to try to help you pare down the important things that I really want you to know. So, yes, and then we're going to do final exam review.
Oh, okay.
Yeah. Okay, great. So here are the drugs we're going to be covering. So there's 8 main classes of antibiotics that we're going to be talking about. That's going to be the penicillins, the cephalosporins, carbapenems, vancomycin, tetracyclines, aminoglycosides, sulfonamides, and fluoroquinolones. And then we'll talk a little bit about drugs for TB. That's going to be our antimycobacterials, and then some antifungals and antivirals. I will say I do have information on these slides a little bit about the specific bacterial illnesses that some of these antibiotics treat. I am not going to test you on that. So I'm not going to say, oh, which antibiotic are you going to pick for scarlet fever and which antibiotic are you going to pick for rickettsia? It's more of like an FYI, okay? So if you listen to the Principles of Antimicrobials lecture, a lot of that information is going to be on the quiz this week, so make sure you do review it. But I really more so care about you understanding and knowing, if a patient's being treated with an antibiotic for pneumonia, how do you know they're getting better? Not necessarily being able to say, this is the exact antibiotic for this. I want you to understand that, we do cultures to determine the organism that's causing an infection on a patient. We do sensitivities to understand what specific antibiotics an organism is going to be susceptible to, right? So that's how we can choose the proper antibiotic to reduce our risk of, what's the word? Antibiotics, like tolerance, right? Or not tolerance, what's the other word? Resistance, thank you. So I want you to understand those things, but again, I'm not going to ask you, which antibiotic treats anthrax, okay? All right, so we're gonna cover penicillins first, okay? So penicillins were the very first antibiotic ever created, right? And it was created from mold. You guys have probably heard that little trivia fact before, potentially. So they've been around for a really long time. They're very commonly used. Antibiotics, their main mechanism of action is disruption of the bacterial cell wall. So they're going to be a bactericidal antibiotic, meaning that they kill the bacteria, okay? Versus a bacteriostatic antibiotic would do what?
Like put it on hold?
Yeah, stop the growth, but not necessarily completely kill it, right? So if we have a bacteriostatic antibiotic, what has to take over for us to get better from our infection? Our own immune system, yeah, exactly. So penicillins are going to be bactericidal, and I also talked about in that Principles of Antimicrobials lecture about selective toxicity, right? So selective toxicity is the concept of we are able to treat infections because of selective toxicity, right? So we have medications that are going to treat or impact that organism somehow, but not harm us. And I talked about how with chemo drugs, we have difficulty with selective toxicity. That's why patients have a lot of complications when taking chemo medications, because it's hard to isolate and treat just the cancer versus damaging all of our cells. So the way that this is going to work, so our microbes, right, our infectious agents, have a cell wall that's very rigid, but it is semi-permeable, so stuff can come in and out of it. And the pressure outside of that cell wall or that membrane is very, very high. Normally, that prevents expansion and swelling of the cell. But bacteria do normally take up some water due to that high osmotic pressure. So what is going to happen here when we're administering penicillins is they disrupt the cell wall, meaning that that bacterial cell is going to absorb water, and it's eventually going to explode or lyse. It's going to die. That's your little explosion there. So, oh, did somebody ask a question?
No, I was laughing, sorry.
Oh, okay. So these are going to be bactericidal, right? They're going to completely kill that cell. And it doesn't work on our cells because we don't have cell walls, right? We have cell membranes, but we don't have cell walls in our cells. So that's where the selective toxicity piece comes in. I don't think I mentioned in that lecture the difference between gram-positive and gram-negative bacteria, but you guys took micro, right? Maybe? So maybe that rings a little bit of a bell, right? We have gram-positive, gram-negative, and one of the big differences is there's an additional layer, a protective layer beyond the cell envelope for our gram-negative bacteria. So some of our gram-negative bacteria, as a result, can be a little bit harder to treat sometimes. For the most part, penicillins primarily act on our gram-positive bacteria, but as antibiotics, not just penicillins, but other antibiotics have been developed, coverage has been expanded. So, generally newer generations of antibiotics oftentimes can treat a lot more infections because they work on gram-negative and gram-positive. So there's a lot of different types of penicillins, okay? And I think I'm only putting a couple of them on your exam. I think I said penicillin G and then maybe like ampicillin or nafcillin. I don't remember off the top of my head, but there's only going to be a few on the exam. And so what I really want you to understand and see from here is that you can see as we have different generations of penicillins, so you've got your penicillin, your nafcillin, your oxacillin, piperacillin, right? Over time, they go from being a very narrow spectrum, meaning they only treat a small, a few infections or a few infectious agents, to being very broad spectrum, meaning that they can treat a lot of different bugs. So you can see at the top, we're only really treating gram-positive. It's very narrow spectrum. And then as you go towards the bottom, towards our later generations of penicillins, you'll see that they can treat gram-positive and negative. They're very broad spectrum.
So narrow is positive, broad is both.
Narrow, not necessarily. Narrow just means it only treats a limited, a very small number of infectious agents. Broad means it treats a whole bunch. Yeah. So I do want to talk about, your book has a lot of discussion about beta-lactam, beta-lactamases, and penicillinases. So a lot of our antibiotics have this beta-lactam ring, specifically the first three antibiotics we're going to be talking about today. So our penicillins, our cephalosporins, and our carbapenems. The beta-lactam ring is that little red ring, okay? It's this chemical makeup of the antibiotic itself. And all antibiotics that have this beta-lactam ring have the same mechanism of action, meaning that they're bactericidal, and they do that by disrupting the cell wall. But we know, right, bacteria have the ability to change, evolve, and mutate in response to their environment, right? If they want to survive, they've got to do the best they can. So there are some bacteria, and they're referred to as beta-lactamases, that have developed the ability to create enzymes that destroy that beta-lactam ring. So when we destroy an integral chemical part of the antibiotic doesn't work anymore. So if you see the term beta-lactamases in your text, that's referring to the specific type of the specific type of microbe that destroys the beta-lactam ring. If you see the term beta-lactam antibiotic, that's talking about the drug itself. Okay, and then you might see the term penicillinases in your book as well. Remember, anything that ends in ASE means enzyme, right? So penicillinases are going to be bacteria that target the beta-lactam ring specifically of penicillins. But again, as these newer generations of penicillins have been developed, they found ways to alter the beta-lactam ring. They found ways to strengthen the beta-lactam ring. So that way, those bacteria that go in and dissolve and disrupt that beta-lactam ring aren't effective in doing that anymore, and the antibiotic works. Does that make sense? Mm-hmm. Your principal differences between the penicillins, and we're going to get into this in just a minute, are going to be their like antibacterial spectrum, so what kinds of things they can treat, whether they're narrow or broad spectrum, how stable they are in stomach acid, and then how long they're going to be working for, their duration of action. So one of the ones that is on your test is going to be penicillin G. This is going to be a more narrow spectrum penicillin. It's gram-positive. It treats some gram-negative cocci, but for the most part treats gram-positive bacteria. We use it for a lot of different things. Again, I don't expect you to memorize the uses that, oh, this is the one we treat strep throat with, or anything like that, okay? It has 4 different forms, and all of these forms are different salts. Don't think about this as like sodium, right, when we're thinking about sodium in the bloodstream. But remember, chemistry, a salt is any kind of chemical compound that's formed by like a cation and an anion that are bonded together. And so there are a couple of things that are special based on the type of form of the penicillin. So we're going to get there in just a second. So our penicillin G is not stable in stomach acid. Actually, all of our forms of penicillin are for the most part not stable in stomach acid. The only one that commonly is given orally is going to be like your amoxicillin, but a lot of our other penicillins are not very stable in stomach acid, so oftentimes they are given by alternative routes like IV or IM. For our two different salt formulations, so our penicillin sodium and potassium are both given IV. And the reason for that, I think about electrolytes that dissolve easily in water, right? So sodium and potassium would be that, versus our benzathine and our procaine penicillins, we don't give IV because they aren't easily dissolved. And then our penicillins are also renally excreted. I will say for most of our antibiotics, the majority of them are metabolized and excreted via the kidneys. So oftentimes we have to be very cautious in patients who have pre-existing kidney disease because of that. I've literally seen patients come in who have been on antibiotics outpatient and they come in with like AKI because the antibiotic is harming their kidneys. So our big side effects or toxicity things, allergies. So a lot of people can be allergic to penicillin. We definitely want to make sure that we ask patients about what kind of allergy they have, right? We want to know, are you having an anaphylactic allergy? Is your throat closing? Or is your allergy, GI upset or something, right? We want to know what their allergy is. So we can know how serious it is. Obviously, if a patient has an anaphylactic penicillin allergy, we're not going to be giving them penicillin, right? Versus if they maybe just have some untoward side effects, we may give it to them, especially if that's the only thing that can treat their infection. I will also tell you, which I think I put this on these slides, but because of the very similar chemical makeup between our penicillins and then our next two antibiotics that we'll talk about, which is our carbapenems and our cephalosporins, there is a very small risk that patients who have an allergy, and specifically an anaphylactic allergy to penicillins, can also have that same allergy to our cephalosporins and our carbapenems. So it's something to be very cautious of and watch out for. What do you guys think we would do? Let's say that a patient has like an anaphylactic penicillin allergy, but that's the only thing that can treat their infection. And if we don't treat their infection, they're going to get septic and die. What do you think we would do? Okay, we might pre-medicate them for sure. What else?
I was going to say dose it with like epinephrine.
Yeah, so like epinephrine, Benadryl. Okay, you guys are thinking really well. Yeah, so we can do like desensitization sometimes. So we can administer really small doses to get the patient kind of used to it. Obviously, these are not circumstances where we're going to like give somebody some penicillin and say, okay, take it at home, good luck. They would be monitored like in a healthcare setting, probably a hospital, if this was the case. It's, I would say, very rare for this to happen, but there are some infections out there that can only be treated by one antibiotic. And so if the person is allergic to that, we have to figure out how do we mitigate this? Because again, an infection that goes untreated and it becomes rampant and our body can't handle it, patient will become septic, they will die if we can't treat them, right? Okay, so we also, one of our big things is pain at the IM injection site. So oftentimes if you hear people talking about going to the doctor and then they gave them like an antibiotic shot in their butt, oftentimes it's going to be penicillin. Their butt will be very sore. Generally, we just recommend to treat with like a warm compress and it will resolve within a couple of days. And then we do have some side effects that are specific to those 4 different salt forms. So our procaine, we can see some behavioral changes. Patients can be like confused. They can have increased agitation or like unusual thoughts and behavior. And then, of course, with our potassium and sodium, because they contain electrolytes in them, we can see potentially electrolyte imbalances with those patients as well.
Is there one called the peanut butter shot? Was that penicillin? It's like that brown looking shot. It doesn't look like peanut butter.
I don't know. I don't think I've ever actually given penicillin IM, to be quite frank with you. They do it a lot of times in like outpatient settings, but I don't work outpatient.
Well,
So.
I had to get it basic training. They gave it us in our butt and it hurt so bad.
Yeah.
So that's what it is. And it literally looked like peanut butter.
And then our drug interaction here is going to be our aminoglycoside antibiotics, which we'll talk about. And with our aminoglycosides, this is actually kind of a good drug interaction. So when penicillins are used in combination with an aminoglycoside, so like for example, if you've ever seen on somebody's like MAR, like piperacillin and tazobactam, which is Zosyn, it's a really commonly used antibiotic. That's a combination of a penicillin with an aminoglycoside. And so it makes it, basically they potentiate the effects, right? So it makes it easier for the penicillin to kill the bacteria when used with an aminoglycoside, particularly for certain bacteria that may be slightly more resistant to penicillin. There is a caveat to go along with that though. So we never, let me back it up. They can come pre-mixed how they are, but we never take like a penicillin itself and the aminoglycoside itself and mix it because it can cause it to be unstable and inactivate. So when they're pre-mixed, they have stability compounds in there that help to make it where we don't have this problem. But we would never take like a penicillin and an aminoglycoside bag and mix them together ourselves because it will inactivate it. Yes. Yes, it's good. It helps it work better. Yeah. Okay, so we talked about penicillin G. You've also got like nafcillin, amoxicillin. You can see all of our penicillins end in cillin, right? So that makes it easy to remember. We also have some beta-lactamase inhibitors that help to inhibit beta-lactamases. And again, these can also be used in combination with penicillin. So if you ever see like amoxicillin and clavulanic acid, right, or augmentin, that's a really common one. Again, those are things that are going to basically help extend the microbial spectrum of the drug, making the penicillin more effective.
You want us to know the 4 forms of penicillin?
The salt forms, you mean?
Yeah. Potassium penicillin G, procaine penicillin G.
I want you to know them. Are you asking if it's on the test? I don't remember off the top of my head. So you might want to pull up the blueprint and look. Yeah.
But they're not going to do like different things. You just have to know that.
Correct. Yeah, just those few differences. Yeah. Yeah, they're all going to work on treating whatever infection the patient has, right? And their mechanism of action is going to be the same because they're penicillins. So, a few things, right? Nursing implications, if you will, right? We want to make sure that we draw cultures before treatment. Why is that so important?
So we can figure out what bacteria you have.
Right, to know what bacteria we have, to make sure that we're treating it with the appropriate medication so we can reduce the risk for, yes, resistance. Excellent. We want to watch for high-risk patients, so contraindications and precautions. So who do you guys think would be high risk for penicillin? People with kidney disease. Okay, what else? Definitely. Yeah, I would say older and younger, like anybody generally on like the very far end of the spectrum, like very, very young, like babies and stuff, and our very, very elderly patients are going to be at risk for, you know, potentially more adverse effects, drug, particularly elderly people, right? Polypharmacy, things like that. So I would watch that. What else? What's a really big bad thing that can happen?
Pregnancy or lactating moms?
I don't think there's anything with pregnancy on this one. What if somebody gave me penicillin and I was like, I can't breathe?
Allergy.
Anaphylaxis, yeah, or allergy, yeah, good. So watching for that, assessing for that allergy, identifying the appropriate type of reaction, so making sure that's documented in the patient's chart. They have that allergy ban on for safety. For the few forms that can be taken orally with penicillin, we generally recommend that they're taken at least 1 hour before or 2 hours after meal to help with absorption. If we're giving IM, we want to make sure that we're actually injecting it into the muscle, right? So utilizing the correct technique. Not mixing the penicillins and aminoglycosides ourselves in the same bag, right? That's going to inactivate those compounds and it's not going to do anything for the patient's infection. We want to make sure that we watch for those adverse effects, right? Overall, again, pretty minimal, but I would definitely be watching the patient's kidney function, watching for signs of allergy, watching for, you know, soreness at the injection site, things like that. This one's really big, right? Teaching our patient to complete the prescribed course. Even if you feel better after a couple of days, keep taking your antibiotics, right? Don't save them for the next time that you're sick. Don't, stop, because number one, it might not completely clear up your infection. And number two, again, we have the risk for promoting resistance there. And then monitoring for drug effectiveness. So if I said that the patient was getting penicillin for an infected wound on their foot, how would we know that they're improving, that the drug is working?
Lower inflammation.
Okay, so decrease in inflammation, less redness, less swelling and pain at the site. What else?
What about white blood cells, maybe?
Oh, looking at their white blood cell count. Good. What else?
The color of drainage.
The color of the drainage. Yeah, maybe it was like purulent before and now it's like serosanguinous or serous, right? Excellent. What else?
No fever.
Oh, did you say no fever? Excellent. What else can we do? Maybe the patient's like taken their full course of antibiotics, but we're not 100% sure the infection's gone. Cultures, yeah, whether it's a wound culture or blood cultures or sputum cultures, right? We can do another culture at the end of treatment to make sure that infection's cleared up. Very good. Okay, so our next one's going to be our cephalosporins, okay? These are also a beta-lactam antibiotic, so they have that beta-lactam ring, right? That means that they're going to have the exact same mechanism of action as our penicillins. So they're going to disrupt the synthesis of the cell wall, blowing up the cell, killing the bacteria. We have 5 different generations of our cephalosporins. And again, like I mentioned, generally your newer drugs are going to be the ones that have that very broad spectrum activity or be able to treat super resistant type bugs. So our newest one, our 5th generation, our Teflaro, is the only one that has activity or action against MRSA, which is methicillin-resistant Staphylococcus aureus. So here's your 5 generations. You definitely will need to know this. So however you want to memorize it, memorize it. So you can see, for the most part, our activity against our gram-negative bacteria goes up with the generations, with the exception of the 5th generation. It's a little bit off there. But again, as those generations progress, we have more activity against gram-negative bacteria. In terms of our resistance to beta-lactamases, remember beta-lactamases are the bacteria that can develop the enzyme that dissolve the chemical structure of the antibiotic, making it ineffective. So our 1st generation's not very resistant or effective against beta-lactamases, but again, as these have been developed, you see our 4th and 5th generation are very effective against those bacteria that have evolved. And then in terms of the distribution into the CSF, why would this be important to know if the antibiotic can get into our cerebrospinal fluid?
It can get into the brain.
It could get into the brain, which would be good or bad?
Yeah.
Are we sure it would be bad?
Depends if you're trying to treat something.
Exactly, yeah, it depends on what we're trying to treat. Yeah, so if we're trying to treat an infection in the brain or an infection in the spinal cord, we want something that is easily distributed into CSF, right? Maybe we're trying to treat bacterial meningitis or something like that. If we're not trying to treat that, I would, be cautious, but that doesn't necessarily mean it would be totally contraindicated or anything like that.
When it says resistance to the beta-lactamase, what does that mean? Is that just building resistance in general?
No, it means that the antibiotics, so remember the beta-lactamase is going to be the bacteria that have developed the ability to make an enzyme that dissolves the antibiotic, essentially, dissolves the beta-lactam ring. And so it means that the bacteria that have developed that, for example, like our 1st generation has very low resistance. So if we're treating this patient and this bacteria is evolving and has developed the ability to dissolve the beta-lactam ring, our antibiotic's probably not going to work very well for the patient. Versus when we look at our 4th generation, it's got the highest resistance to beta-lactamase. So even if that bacteria is trying to dissolve that beta-lactam ring, make the antibiotic ineffective, the antibiotic's still probably going to work because it's got resistance against those organisms.
And then that makes sense, but the activity against gram-negative, can you explain that?
Yeah, so it just means that whether it works on gram-negative versus gram-positive. So these are mostly going to work on gram-positive, but you can see like our 1st generation didn't have a lot of activity against gram-negative bacteria. So if I was treating, E. coli, which is a gram-negative, I probably wouldn't pick a 1st generation cephalosporin. I would want to pick a 4th generation because look, it's got the highest activity against gram-negative.
Okay.
Yeah, I don't know off the top of my head if cephalosporins treat E. coli, but just an example for you, okay?
Alright, so just make sure I got it. So the resistance to the beta-lactamase is basically like the bacteria's ability to make the antibiotic ineffective.
The resistance to beta-lactamases is the antibiotic's ability to not succumb to the bacteria's ability. Like, that's what that column is saying.
Makes sense.
A bacteria being a beta-lactamase is the bacteria's ability to make the antibiotic ineffective. Yeah. So what if I said, okay, well, which generation of cephalosporins is going to be the most sensitive to beta-lactamases? First generation, yeah. It's got the least amount of resistance, meaning it's going to be the most sensitive or susceptible to our beta-lactamases. Okay, so what if I said which generations would be most appropriate for a CNS infection?
Second, fourth, and fifth.
Third, fourth, and fifth. Yeah, so all the ones that have the distribution into the CSF. What about which one has the broadest spectrum activity against gram-negatives?
Fourth generation.
Fourth, right? Because it's got the highest activity against our gram-negative. Excellent. And then which one, this one's not on this slide, but which one has activity against MRSA?
Fourth generation 5.
Fifth generation. Good. Excellent. And then you can see I put the little prefixes up there, but all of your cephalosporins will have either CEF or CEPH in the name of them. So with our pharmacokinetics, in general, these are given parenterally. They're not very well absorbed in the GI tract, with the exception of our cefuroxime, which is an oral medication. They're generally eliminated by the kidneys. Remember I said most of our antibiotics are eliminated by the kidneys, with the exception of our ceftriaxone or Rocephin. It's eliminated by the liver. And then, like on the previous chart, right, third, fourth, and fifth generations are going to have action or reach the CSF. So with our side effects and toxicity risks, we've got the risk for allergy, right? If a patient's allergic to what, they could be allergic to this too.
Penicillin.
Mm-hmm. Excellent. We've got the risk for thrombophlebitis, which is just inflammation of the vein, right, wherever it's infusing. So what would we want to do as a nurse to minimize or catch that before it happens?
Give like aspirin. Oh, no.
Not give aspirin. What do you guys think? Okay, so maybe infuse it slower. What else?
Check the patency.
Yeah, check our IV for patency and do what while it's infusing?
Watch the IVC.
Yeah, monitor frequently. Yes, good. We can also, if we have maybe more than one IV, give a dose in this one time and then give a dose in this one, rotate our sites around a little bit to reduce that risk as well. There is a risk for hemolytic anemia, which is an anemia that develops from the destruction of our red blood cells. So patients may have on their labs low red blood cell count. They might complain of like being cold all the time or fatigued all the time with that. We do have the risk for superinfections. What's a superinfection? Yeah, another infection that you get while you're on the antibiotic. And how do they happen?
Because you kill your own, what's it called?
Microflora.
Your own, your microflora.
Yeah. So some antibiotics can disrupt our own microflora, right? And as a result, other bacteria can take over and we can develop some kind of infection. So super infections that you hear about a lot are like people developing like yeast infections or like thrush oral yeast, right? Or C. diff is another one that's a super infection that people can get oftentimes. But they can manifest in any way, but those are the ones you'll commonly see. Super infections aren't super common with this one, but there is the potential there as well. We have the risk for bleeding, specifically with our Cefitan and our Rocephin. We have bleeding risks. So we want to watch our patient, right, for signs of bleeding, monitor their PT, things like that. And then C. diff, if the patient does develop a superinfection, it's more commonly going to be C. diff with our cephalosporins. So with our drug interactions, alcohol is a big one. Do y'all remember when I talked about disulfiram type reactions? What kind of reaction does the patient have with that?
Really, really violently ill.
Violently ill, yeah. Dizziness, flushing, nausea, vomiting, palpitations. Terrible. Feels terrible. So that's the reaction we have with our cephalosporins and alcohol. With specifically the cefitan and the rocephin, right, the ones that can cause the risk for bleeding, we want to be cautious in drugs that also cause bleeding, so like our anticoags, our antiplatelets, and thrombolytics, our NSAIDs, things like that. And then this is a population-specific interaction, but our calcium and our rocephin, it can be a fatal reaction, particularly in like newborn babies, like neonates. So if a patient has to receive this antibiotic and calcium, we separate the administration for 48 hours. So like if I gave calcium, it's going to be 2 days later before I can give the rocephin. And the reason for that is it can cause fatal precipitates to form in the lungs of newborns.
That's just for babies?
Just for babies. Yeah, we can do it fine and administer right after the other or whatever with adults. So just babies.
Does these have the same use as the penicillins?
Like for the types of diseases it treats?
Yeah, like strep.
Yeah, for the most part. When given with calcium. So our nursing implications, these are going to look probably a lot like our penicillin nursing implications, right? Draw cultures. You will definitely see stuff about that again because I'm going to emphatically say it about 20 times today. Draw cultures. We always get our cultures before or after we give it antibiotics? Before. Excellent. To identify the microbe, right? Understanding the differences in the generations is going to be really important. Watching for our high-risk patients, so generally they're safe in pregnancy and breastfeeding. Assessing for the allergy, right? Because of the risk, especially if they already have a history of an allergy to penicillin. If the patient is experiencing like gastric upset or GI upset with this medication, it's okay for them to take it with food. Avoiding alcohol. That's a good rule of thumb for every medication, but specifically to reduce their risk of having that disulfiram violently ill reaction. Watching our IV sites for phlebitis, just like with our penicillins, the IM injection can be very painful. So teaching patients, to work the muscle, massage it, warm compress, things like that. Observing for those adverse effects. Taking the prescribed course, that's something else I'll probably say about 20 times today. Take the whole thing. And then, again, monitoring for effectiveness. How do we know it works? And I'm not going to say, oh, the patient has, scarlet fever. Select all that apply for how you know the medication's working. I'm going to say, okay, well, the patient is being treated for bacterial pneumonia, or the patient's being treated for a wound infection. Something that will be very evident and easy for you to identify. Is the patient getting better or worse, okay? So our third group of beta-lactam antibiotics is going to be our carbapenems, right? So we had our penicillins, our cephalosporins, and our carbapenems. They also have the beta-lactam ring, meaning that they are going to be having the exact same mechanism of action where they destroy the cell wall of the bacteria. They're going to be bactericidal, meaning they kill the bacteria completely. And our carbapenems have a very broad spectrum of things that they can treat. So the one we'll talk about is imipenem. You can see it says penem at the end, like carbapenem. That mechanism of action, again, here's another repeat, weakens the bacterial cell wall, bactericidal. A nice broad spectrum of action, so it's resistant to a lot of those beta-lactamase bacteria that have evolved. This one is not active against MRSA, remember, so that's going to be generally our just 5th generation cephalosporins. This can be given IV or IM. It's renally eliminated via the kidneys. Your big adverse effects, so patients will have a lot of GI effects sometimes with our carbapenems, so like nausea, vomiting, diarrhea, stuff like that. Risk for super infections, again, it's a small risk, but with any of the antibiotics, you want to watch out for that. And then the risk for allergic reactions. So again, because this one has a similar chemical structure, if a patient's allergic to a cephalosporin or a penicillin, that risk is here for this one as well. And then our big drug interaction here is going to be our valproate, or valproic acid, right, which is like Depakote. It's one of our seizure medications we talked about. So when taken with a carbapenem, the efficacy of our valproic acid is going to be decreased. So the patient's going to be at a higher risk for seizures. This is just like a fun little FYI, but this is imipenem and cilastatin. Cilastatin is a substance that helps to inactivate an enzyme in the kidneys that like excessively breaks down our carbapenems. So you may sometimes see carbapenems. You'll be like, what's that extra thing that's mixed in with that medication? It's to help prevent us from breaking it down too fast before our body can use it, basically. It's just an FYI. Next, we'll talk about vancomycin. So this is in its own special little category. Vancomycin is a very, very widely used drug, particularly in the hospital. It's actually the most widely used antibiotic in U.S. hospitals. Vancomycin is going to be a very more of a narrow spectrum antibiotic. It's a really common choice, particularly for patients who need to be treated with a penicillin potentially. It can treat most things that penicillins can, particularly if the patient has an allergy to penicillin. We can try vancomycin oftentimes. We use it to treat C. diff infections, and then it does have some potential action against MRSA. So keep that in mind, right, again, along with our 5th generation cephalosporins. So the mechanism of action is similar but a little bit different to the first 3 that we talked about. It does weaken the cell wall, but instead of increasing the permeability where water flows in and the cell explodes, it actually binds to molecules that are used to build up the cell wall. And so that's how it weakens the cell wall. It is going to be bactericidal though as well, so it basically makes it where the bacteria can't build the cell wall appropriately. This one does not contain a beta-lactam ring, so this one is not a beta-lactam antibiotic.
So it weakens the cell wall by binding to
molecules or like the building blocks of the cell wall itself. So it can't build it, yeah. Versus the other ones increase the permeability, so water goes into the cell and it blows up. So in general, our vancomycin has pretty poor GI absorption, but we do sometimes give oral or rectal vancomycin to treat GI-specific infections. So remember when we talked about like the respiratory drugs, right? We give some of those inhaled and they work directly on the site of action versus having to be in systemic circulation. The same thing is true for this. So like if I'm treating a patient for C. diff or some kind of, bacterial colitis, oral vancomycin would be chosen because it can work directly on the site of action where that infection is. These again are also renally excreted, so we're going to be watching out for those patients who have pre-existing renal dysfunction. We're going to want to be looking at their kidney labs. Your big side effects, we've got a risk for renal failure, particularly when taken with other drugs that can be nephrotoxic, so watching out for that. Oftentimes with vancomycin, we'll do something called renally dosing. We do this with a lot of medications, where patients who have some kind of pre-existing renal disease or maybe their BUN and creatinine just don't look great, the pharmacy will adjust their dose from day to day based on what their kidney labs look like, or give them like a reduced dosage. Vancomycin specifically is one that we monitor like the peak and trough levels of the medication, monitor their kidney labs, and again, it's something where, technically the patient may be scheduled for a daily administration of this, but the pharmacist will go in and look, and they might hold medications from day to day depending on what the patient's labs look like. We've got the risk for ototoxicity. So what kind of things might a patient complain of if vancomycin was causing ototoxicity?
Like dizziness?
They might have tinnitus, they might have like dizziness potentially, things like that, hearing difficulty. We've got, again, that risk for thrombophlebitis, so monitoring those IV sites, rotating the IV sites, checking for patency before we hook it up, right? And then we have this unique thing, and this is what's pictured here on the slide, red man syndrome. So red man syndrome is caused when vancomycin is infused too rapidly. So it can cause patients to have a rash, they can become very flushed, they can become hypotensive and tachycardic. So in general, for vancomycin, we always administer over at least an hour to prevent this from happening. If your patient is developing red man syndrome, what do you guys think that you would do? Probably stop it or slow it down. I wouldn't necessarily, I mean, if they were becoming, like, having anaphylaxis, we could give them epi, but I would probably just monitor them. They might need some antihistamines, like a Benadryl or something for the rash. Normally, once you slow down or stop the infusion, though, it's going to resolve within a brief period of time. I would definitely monitor their vitals, right, because of the tachycardia and hypotension.
So if they get the red man syndrome, can they continue to take it, or is it just a thing that happens and then they
can continue to take it. It just happens when we give it too fast. So some patients may be a little more sensitive or susceptible to that than others. So that's why we generally do about an hour. But if a patient does develop it and you're giving it at the right rate, maybe we need to slow it down even more, potentially. Good question. And then again, with our drug administration, so we draw peak and trough levels of this medication very commonly, and that's to monitor how much of the drug is in a patient's body, right? So peak is when the drug is at its peak, trough is going to be when it's at its lowest point, how much of that drug is there, and that helps guide the dosing of our vancomycin. Because remember, our main goal is to make sure we maintain medications at a therapeutic level, reduce the risk of toxicity, but maximizing the efficacy of the medication. So with our vancomycin, culture, sensitivities, right? Watching for those high-risk patients, particularly those who are renally impaired. Our baseline labs definitely want to look at their kidney function, assessing for allergies, checking that IV site, making sure that they're not developing red man syndrome, so infusing at the appropriate rate. Understanding that we might, even though it's not greatly or well absorbed for systemic circulation in the GI tract, if a patient has a GI infection, we might be giving it for that, specifically C. diff. Watching for those adverse effects, being cautious with other nephrotoxic drugs, so our aminoglycoside antibiotics, our cyclosporines, our amphotericin, our NSAIDs, right? Other things that we know can harm the kidneys. And then again, watching for drug effectiveness. How do we know it's working and our patients getting better? We're going to pause and talk about C. diff. So this picture, I believe, comes from page 1048 in your book. But what causes a C. diff infection? Does anybody know? Yes, it can be caused by superinfection. What if it's not caused by that? What else could cause it?
Certain antibiotics.
So certain antibiotics potentially. What else? Yeah, so it can be transmitted from person to person, or healthcare provider to person, right? So from an infected person to a non-infected person. So what happens is this C. diff bacteria, invade the gut, and they form these toxins that damage the lining of the colon. So it causes like a lot of inflammation, infection. What sign and symptom do you see most commonly with C. diff? Diarrhea, yeah, exactly. It leads to diarrhea. So patients can also have like abdominal pain, right? Comes with the cramping in the diarrhea territory. They can have nausea, fever because they have an active infection, right? And if it escalates really significantly and it's not treated, it can escalate to a colitis, Patients can have bowel perforation, sepsis, death. Like that's like on the really dramatic end of things. But if a patient's not treated for it, it can escalate. So it is transmitted from the fecal-oral route. So it does, make you nervous when you think about that. It's like, oh, that's kind of gross. So we want to make sure that we have excellent hand hygiene when we're taking care of patients with C. diff. Has anybody had one of these at the hospital yet? A C. diff patient? I see a little bit of yes. What did you have to wear? Gown and gloves, yeah, for sure. So they're gonna generally be on like contact environmental precautions, right? Meaning that anything in that room could technically be like poop infected, right? So we always wear gown and gloves, even if you're like, oh, I'm not gonna, touch the patient. Anything in that room could have C. diff spores on it, you don't know. So the rooms get like specially cleaned and stuff like that to reduce hospital-acquired C. diff infection and transmission and those kinds of things. So if somebody's having chronic diarrhea, what kind of complications do you think they would have? Dehydration, electrolyte imbalances, perfect. Oh yeah, skin breakdown's a good one, yeah, for sure. So those would be things that we would watch out for. And people who are going to be more at risk are going to be people who are immunosuppressed, people who are on antibiotics, right, because of that super infection. People who are in the hospital, elderly patients, right? All of those things are going to put patients at a higher risk of developing C. diff. We diagnose it generally with a stool sample. They test for the toxin. And general criteria are like if the patient has more than 3 loose stools within 24 hours is when we're kind of thinking, maybe we need to send down a C. diff sample. And it's generally treated with vancomycin, like we talked about. And then there's another antibiotic called metronidazole or Flagyl. Oftentimes those can be used in conjunction to treat really stubborn C. diff infections. What's different or special about hand hygiene with a patient on like contact environmental or with C. diff versus any other patient? You gotta wash your hands with soap and water, right? Why? To kill the spores, yeah. Our alcohol-based hand rubs are not going to kill the spores, so we can transmit it. So you always want to make sure that you wash your hands with soap and water. Utilize good hand washing technique, right? Warm water. Antibacterial soap is nice, but even just regular soap is fine. And then the use of friction and enough time to make sure that we're killing those spores. And I don't remember if I think I put the hand washing thing in the principles of antimicrobials. So, review that, okay? Okay, so back into our antibiotics. So our next group is going to be our tetracyclines. These are going to be very broad spectrum. These are bacteriostatic antibiotics. So this is going to be the first category that we're talking about that's bacteriostatic. And the way that these are going to work is they're going to inhibit protein synthesis in our bacterial cells. Specifically the protein synthesis related to like their RNA transfer, so the replication of the bacteria. We've got 4 different drugs. They all end in cycline, right? Tetracyclines end in cycline. I think I'm only putting one of them on the test, but these are more of just a FYI, so you can, see the names and become kind of familiar with them. And again, we've got a lot of uses here, uses that I'm not going to test you on, but that are fun to know. So we can treat a lot of different things with our tetracyclines. So in terms of our pharmacokinetics, we do have a few different groups based on their pharmacokinetics, so like their action, whether they're short, intermediate, or long-acting tetracyclines. Most of our tetracyclines have decreased absorption with food, so we want to give them on an empty stomach. And then depending on the group, which I've got it's on the next slide, a little table, some of them are renally eliminated, some of them are hepatically eliminated. So again, depending on which kind of impairment the patient has, we'd want to be very cautious. So your side effects, we do see some GI effects for patients. They can have like nausea, vomiting, diarrhea, abdominal cramping, that kind of thing. I will say that can be mitigated or improved when taken with food, but it can also decrease the absorption. So it's kind of like a 50-50, what do you do? You know, if the patient needs the medication and you want to promote compliance and those GI effects are just really limiting, then they can take it with food. Just know that the absorption is better on an empty stomach. Tetracyclines bind to the calcium in our bones and teeth, so it can result in basically like staining of the teeth and bones. And so because of this, we do not give this to children who have like developing teeth. So we don't give it in pregnancy, particularly after the 4th month, or children less than 8, because it can cause permanent, irreversible staining of their teeth. Your biggest or most likely superinfections here for our tetracyclines are going to be your candida, which is your yeast, and then your C. diff. And then again, because of the metabolism rate, hepatotoxicity or renal toxicity. Your drug interactions, all of these ones listed here, the milk, the antacids, the calcium or iron supplements, the magnesium laxatives, all of those are going to decrease absorption of our tetracycline antibiotics. So if we have to give these with our tetracyclines, we want to generally do it either 1 hour before or 2 hours after these agents. This is table 90-1, page 1054 of your book. I don't expect you to memorize this, but just understand that whichever one I put on the test, understand whether it's renally or hepatically metabolized, okay? And the biggest difference between the class, the short, intermediate, or long-acting is how frequently we have to dose it, how long they're working for. Here's a little picture of the teeth staining with tetracyclines, right? Which is why we don't give it to pregnant people after how long?
After the 4th trimester?
Fourth month. Shayla, you're killing me today.
I'm killing myself.
The 4th trimester, that sounds awful. I hope nobody here has to ever go through a 4th trimester. After the 4th month, and children under the age of? 8. Yes. So now we have our aminoglycosides. This is a more narrow spectrum, right? Meaning it doesn't treat as many different types of infection. They're going to be bactericidal. These also disrupt protein synthesis. And they do it in a little bit of a different way, so it's not necessarily related to the RNA and the replication of the bacterial cell, but they actually cause the bacteria to make abnormal proteins, which are not compatible with life. So as a result, the cells die and they're bactericidal. Our aminoglycosides, which this will be on the next slide, but generally end in the suffix myosin, aside from disregard vancomycin because it's kind of in its own category. But all of the other, if you see myosin like MYCIN or MICIN, that's going to be an aminoglycoside. So here we got our gentamicin or garamycin and our tobramycin or our nebsin. Generally, these are not very well absorbed in the GI tract, again, so oftentimes given IV or IM. These ones do cross the placenta and can have toxic fetal effects, so we're not going to give them to pregnant people. And they're going to be eliminated by the kidneys, again, like with most of our antibiotics here. Our side effects, so we've got the risk for ototoxicity. We've got that risk for nephrotoxicity. And then we also have a small risk for neuromuscular blockade. So what other med did we talk about that causes neuromuscular blockade? It's a long time ago. Back when we talked about like cholinergic drugs and doesn't start with an E.
I know you give it to them when they go in surgery.
Uh-huh. Yeah, like the paralytic agent, right?
Nika, start with
A.
A. It does start with an A. Atracurium, remember?
Oh yeah, tertullium.
Yeah, atracurium. So that one is going to be something that we would not give with this because of that risk for that neuromuscular blockade. Now, obviously, if a patient's having surgery and receiving atracurium and they need the neuromuscular blockade, then they need the neuromuscular blockade. But we watch with that or with patients. What's one of the diseases that we talked about where neuromuscular blockade's a little bit of a problem? It also goes along with that group of drugs a little bit. Myasthenia gravis, yes, absolutely. So we would be very cautious about using this in patients with myasthenia gravis because it can exacerbate that neuromuscular blockade that they experience. So it can cause, patients to develop paralysis. It can cause them to have respiratory depression. So yeah, we definitely don't want that. For this drug specifically, though, that neuromuscular blockade can be reversed with IV calcium. So our drug interactions, our penicillins, right? We talked about this back on the penicillin slide. This is a good interaction with our penicillins and our aminoglycosides because they're going to make each other more effective, except for what? Wait, what should I not do with the penicillin and aminoglycoside? Mix them in the bag. Excellent. Because it's going to do what? Inactivate it. Absolutely. And then again, our ototoxic and nephrotoxic drugs, right? So anything that is also ototoxic or nephrotoxic would be a big interaction. There's too many to list and say, but I would watch out for those. And then again, our skeletal muscle relaxant or neuromuscular blocking agents, because of that neuromuscular blockade. We're almost done. I think we only have 2 more classes of antibiotics, so y'all are doing good. Okay, our sulfonamides. They're going to have SULF in the name, like sulfur, okay? Primary use for our sulfonamides is actually really commonly urinary tract infection. They do have some other uses, but if you've ever had a UTI, you've probably been on like Bactrim or Septra, which are both sulfa drugs. These are going to be primarily a bacteriostatic, right? So they're not going to completely kill those bacteria. Our own immune system is going to have to take over and do some work. The way that these work is that they inhibit the bacterial synthesis of folic acid. So if you bring your mind back to whenever you watch the principles of antimicrobials, we can get folic acid from our diet, right? But bacteria have to make their own. So by inhibiting the synthesis of folic acid, the bacteria can't make it, and they're not going to be... They're gonna get sick and start to die off. They don't all completely die off though. That's why it's primarily bacteriostatic. But that's the selective toxicity piece for this one. These are generally PO medications. So these are really commonly given like outpatient again for patients with UTIs. So we do have that risk for, like we talked about last week with the Stevens-Johnson syndrome, we do have that risk here with our sulfonamides. Some patients develop just like a hypersensitivity reaction where they develop just like a little bit of a rash, but some patients can even escalate to that Stevens-Johnson syndrome, which is rare, but it can happen, right? And that's where patients have those rashes that develop into like the sloughing off of the skin. They have widespread like fever and malaise and things like that. We have the risk for hemolytic anemia. So again, the destruction of our red blood cells. So watching our patients' CBC, right? Looking at their red blood cell count, looking to see, are they fatigued? Are they cold? Are they developing, jaundice, things like that. Does anybody know what kernicterus is? It is a disorder for babies. So again, this is going to be one of those like baby-specific things, but it's caused by bilirubin getting into the central nervous system. And normally, like in a normal newborn, bilirubin is bound to the proteins and can't cross through the blood-brain barrier. But when taking a sulfonamide, it displaces that bilirubin and it can from the proteins and lets it cross into the CNS. So we've got the risk for kernicterus with babies, which is why we don't give it to babies. Because that kernicterus can, you're like, okay, what's the big deal? Well, the bilirubin can cause like neurological deficits, it can cause death, things like that if it gets into the brain. So we're not gonna give it to kids who are under 2 months, pregnant women, or breastfeeding moms. And then our renal damage here is not so much about like nephrotoxicity, but our sulfonamides can form like basically like crystalline aggregates, like almost like kidney stones in patients. So we want to make sure that they drink a lot of water when they're taking this, you know, that they're peeing, well, they're probably peeing often because they've got a UTI, but, you know, that they're practicing, you know, good hygiene and not holding their pee when they have to go, things like that. Okay, and then our last major antibiotic is going to be our group, is going to be our fluoroquinolones. So these are going to end in fluoxacin. They're going to be a more broad spectrum bactericidal drug. And these work by inhibiting DNA replication in the bacterial cells. They can be given oral or IV. They're going to be metabolized in the liver and excreted via the kidneys. We've got GI effects. Everything has GI effects, doesn't it, basically? But GI effects, right? Nausea, vomiting, diarrhea. We've got the risk for central nervous system effects here. So patients might have a headache. They could have confusion, restlessness, dizziness, things like that. The risk for superinfection is a little bit higher with these antibiotics than some of our others, so C. diff and Candida specifically. This one is very unique to fluoroquinolones, but the risk for tendinitis or tendon rupture. It's kind of rare, but there was a big study that came out, and a lot of patients who were taking Levaquin had developed Achilles tendon rupture specifically, right? That's the tendon behind your foot. And so if a patient, this just requires some patient teaching. So if a patient starts to develop pain or inflammation in like a joint or a tendon area, we normally will discontinue the medication if possible, but we want to teach them to report that so that way we're aware so it doesn't develop into full tendon rupture. Patients can also have muscle weakness, and then we have the risk for phototoxicity, which is what?
Sensitivity to light.
Yeah, sensitivity to light. So we want to make sure that we avoid like prolonged sun exposure, you know, wear protective clothing, wear sunscreen, stuff like that. So our drug interactions, our cations, these are going to be things like aluminum or magnesium containing antacids, iron preparations, our sucralfate or carafate, which we'll talk more about today with our GI stuff, and milk, all can reduce absorption. So with those, we want to make sure that we take the antibiotic either 6 hours before any of those agents or 2 hours after. And then both for our theophylline, which is, remember, a respiratory drug, right? Or our warfarin, which is our anticoagulant, it's going to increase the levels of both of those medications. So we've got increased risk of theophylline toxicity or warfarin toxicity. we're going to talk about some TB meds now. Do we need a break or are we okay? Okay, we're okay. Excellent. Okay, so y'all know tuberculosis is a respiratory disease. It's caused by Mycobacterium tuberculosis. And how is TB spread? It's particles. Yeah, it's an airborne, aerosolized infection that we can get. It can be really, really difficult to treat due to drug resistance. And primarily the principal cause of resistance of Mycobacterium tuberculosis to the medications is inadequate drug therapy. So either the patient's not on therapy for long enough or they're not getting a high enough dose, things like that. So generally, patients are treated with at least 2 drugs for TB, but with really, really resistant TB, they can be treated with up to 7 drugs, so it's a lot. And we're only going to talk about just a couple little caveats with a few of these medications. Because the treatment is very prolonged, like it can be anywhere from like 6 months to 2 years, obviously patient adherence is a problem, right? Because there's no such thing as a medication that doesn't come without risks. The medications can be expensive, and I mean, just imagine having to take something every day for 2 years or multiple times a day. But when we treat tuberculosis successfully, we'll see a reduction in clinical manifestations, right? So patients' respiratory status will improve, their cough, things like that. We'll see within 3 months improvement on like their chest x-ray. And then within generally 3 to 6 months or so, we'll hopefully see an absence in Mycobacterium tuberculosis from their cultures. So the primary meds are going to be these 4 meds that you will see very commonly and see them in like ATI and NCLEX and stuff, and we're only going to talk about a few of them. But we have our isoniazid, our rifampin, our pyrazinamide, and then our ethambutol. And we're only going to talk about our isoniazid and our rifampin, really. I do encourage you to read the summary of major nursing implications on page 1097 for these. Both 1097, yeah. Both of these, our isoniazid and our rifampin, can be given orally or parenterally, so IV, things like that. Big adverse effects that I want you to just kind of think about and memorize is with our isoniazid, patients can have peripheral neuropathy, right? So they can have numbness, tingling, pain, burning, things like that of like their hands and their feet. This occurs because the drug actually depletes our vitamin B6. And so we can treat that peripheral neuropathy by providing supplemental B6. For both of them, the isoniazid and the rifampin, we've got the risk for hepatic toxicity. So we want to watch out for patients who like lose an appetite, have general malaise, jaundice, nausea, right? All of those liver type signs and symptoms. And something that can exacerbate this is foods that contain tyramine. When y'all get into psych and talk about a lot of your psych drugs, a lot of these have interactions with tyramine containing foods as well. But foods that contain this compound are going to be things that are like generally like aged foods, so like aged meats and cheeses and wines, things like that. What other substance would we want to avoid with hepatic toxicity that a lot of people, alcohol. A lot of people utilize socially, And then with rifampin, it can cause this reddish-orange discoloration of body fluids. So tears, urine, sweat, all of the things. It's harmless, but the medication can cause that. So definitely tell your patients so we don't scare them when they start peeing red, right? So with the TB meds, nursing implications, right? Making sure that we're promoting compliance. If patients have like permanent contacts, they can be stained with rifampin, right, because of that reddish-orange discoloration. So maybe utilizing like daily contacts instead of something permanent for the time that they're on the medication. With both of them, watching for liver dysfunction, right, so watching out for those signs and symptoms, monitoring the LFTs, right, definitely at baseline, and then periodically throughout the treatment. Watching out with our isoniazid for that peripheral neuropathy. If the patient does develop it, let's get them on a B6 supplement. And then we're going to evaluate treatment effectiveness with our chest x-rays and repeat cultures. What patient population or like pre-existing illness would put patients at a high risk for neuropathy already? Diabetes, yeah, good.
So I want to use diabetics.
I wouldn't necessarily use it in caution, but might be more likely that they'll have neuropathies. So I would watch out for that. Okay, and then our antifungals, I think I only put one on here. Yeah, I think I did. Amphotericin B, or fungizone. So this, similar principles to our antibiotics, but it's for fungal infections, right, versus bacterial infections. It is a pretty highly toxic drug, so it's something that we want to watch very closely. It does have, again, selective toxicity against the fungus versus killing our cells. It increases the membrane permeability of the fungus cells. And it actually has fungicidal and fungistatic qualities to it. This one in particular is an IV drug. There are plenty of oral antifungals that exist out there, like diflucan is one of them that treats yeast infections, things like that. But specifically our fungizone is going to be just IV because it's not absorbed in the GI tract. So adverse effects, we can see infusion reactions. Patients might have like fever, chills, they might have nausea or headache. Generally, this is not like life-threatening or anything like that. It will persist for a couple hours after infusion, but once they're done getting the medication, it will resolve itself. But for patients who we know have this already, a lot of times we'll pre-treat them with Benadryl and Tylenol to prevent the fever, prevent that type of reaction. And if that isn't enough, sometimes we can also give like a glucocorticoid to help as well. We've got a high risk for that phlebitis, the thrombophlebitis, so watching out, again, that IV site, monitoring it very closely. Nephrotoxicity, so watching out for our kidney function. We've got a risk for hypokalemia with our fungizone. So even though I didn't put this on the drug interactions, I would probably be kind of cautious with other medications that cause hypokalemia as well, right? Like our loop diuretics, our thiazide diuretics, stuff like that. And then our antifungals can also cause some bone marrow suppression, resulting in anemia for patients as well. So we'd want to be watching their CBC and keeping a close eye on them for that. Your big drug interactions, your nephrotoxic drugs, your flucytosine, both of these are just going to increase, well, both the nephrotoxic, the risk for kidney function. With the flucytosine, it's just going to potentiate the action of that drug. So we're going to monitor our baseline labs, checking our kidney function, our CBC, definitely our potassium, and again, our cultures. Cultures are also used for fungal infections. Watching that IV site, observing for those infusion reactions, right? If we know a patient is going to have an infusion reaction because they've told us that they've had one in the past, pre-medicating with Tylenol and Benadryl. Watching for nephrotoxicity, so monitoring their eyes and nose, their kidney labs. Sometimes we'll give some extra fluids with this medication. Avoiding those nephrotoxic drugs. Monitoring our potassium. Monitoring our CBC for that anemia risk. Taking, again, the whole prescribed course, and then determining how do we know that their infection's getting better, their fungal infection. All right, lastly, we'll talk about antivirals. So the recorded lecture I put for you has the immunosuppressants, and then I have the HIV medications on there. Those are kind of in their own separate little category from the antivirals we're going to be talking about today. But in general, we have a very limited ability to treat viral infections because the virus uses our cells to replicate. So it's very hard to achieve that selective toxicity with viral cells because they utilize our cells as host cells. So we're going to talk a little bit about the flu before we dive into the actual medication. But for the flu, we have two main types, right? Flu A and flu B. And you will probably remember or see things where people talked about like H1N1 or H3N3. That just has to do with specific subtypes of the flu. They're categorized and characterized based on epidemiologic studies, so like what's being transmitted very commonly. And so flu vaccines are made based on the predicted, idea of what couple of strains of flu are going to be very prolific this year. So that's why they don't always work the best, because they're based on a prediction. How is the flu spread? Droplets, yes. So they go through some kind of portal of entry through direct contact with our mucous membranes, right? So if a patient coughs, sneezes, drinks after you, whatever kind of droplets you're becoming exposed to is how flu is going to be transmitted. What's the best way to prevent the flu? Does anybody know? Vaccine's a big one. Good hand hygiene also. What else? Don't go around sick people, yeah, or if you're sick, using good respiratory hygiene, right? Staying away from other people when you're sick. Excellent, perfect. So with our vaccines, it normally takes about 1 to 2 weeks after getting a flu vaccine for it to be effective in protecting you against the flu. Again, taking that with a grain of salt, right? Because it's only going to be effective if whatever vaccine we administered is congruent or matches up with whatever type of flu we've been exposed to, whatever subtype. But generally, the protection of our flu vaccine lasts for about 6 months as well. So that's why we have that really specific, okay, it's flu season, generally from like October to March timeframe, where we get the vaccine, and we really are very deliberate about making sure that we ask our patients, okay, have you had the flu shot? Do you want the flu shot? With all of their healthcare interactions. So our efficacy, right, the effectiveness of the vaccine can be influenced by a few things. It can be influenced by like age and health status, and then of course, again, if the vaccine actually matches the strain that is going around. Okay, what do you guys think about who shouldn't be vaccinated for the flu? Allergic, what else?
You like immunosuppressed too.
Immunosuppressed, yep. Yeah, particularly the live virus or the attenuated vaccine. What else? You guys are so quiet.
It's like allergic to eggs or something.
Yeah, if you're allergic to eggs, there's an egg component in there. If you have a history of what? It's a French thing.
Kissing?
Did I just say if you have a history of kissing? Is that what you said? It's not kissing. It's like it's not a French thing. It's a French word disease.
French fries.
I know. If you guys have all gotten a flu vaccine, I know you've read it on that sheet, or maybe you didn't read it and you just signed it. Yeah, Guillain-Barré, right? So if you have a history of that, we don't give flu shots. I don't know if I said it right. French is not my language specialty.
What's that word again?
What is it? Yeah. Okay, do you want me to just spell it for you?
Yeah.
Okay, it's Guillian, and then there's like a dash or a space, and then Barre.
Oh, good and bad. Oh, okay.
Yeah, okay, yeah. You can say it however you guys want to in your head. Heck, you can say it however you want to out loud, but people might look at you crazy. So yeah, generally, we do give flu vaccines to pretty much everybody age 6 months and older. We are going to want to give like the inactivated vaccine, the one that doesn't have live virus, to people who are immunocompromised or very high risk. So we are kind of cautious in pregnant women, are immunosuppressed, patients with chronic medical conditions we're worried about potentially. But absolute, should not get the flu vaccine would be allergy to the flu vaccine, Guillain-Barré, and then generally if patients have an active fever or illness when they're coming to get a flu shot, we generally say, hey, maybe wait until you get better and then come get the flu shot. So your adverse effects with the flu vaccine, the biggest one obviously is soreness at the injection site. Some patients will sometimes develop kind of like a slight immune response, so they might have a little sore throat, a little bit of slight low-grade fever, runny nose, fatigue, things like that. So we do sometimes see that. But generally, there's not a whole lot of significant ones beyond like an anaphylactic reaction or the Guillain-Barré syndrome. So what do you guys think we're going to do with somebody who like actively has the flu, right? We're probably not going to give them a vaccine right now because they're sick. How are we going to treat them? Tamiflu, or what's the other alternative? Okay, well, or Theraflu. Okay, well, I'll just tell you. Supportive care, right? So we don't really have a treatment beyond Tamiflu to really help us with the flu. So doing things like hydration, helping to manage the symptoms, right? That's what supportive care means. So we'll talk about Tamiflu. So Tamiflu is a really great drug in that it aids in the treatment of flu, but it's not going to be totally eradicate the flu for us or anything like that. It's not like a cure necessarily. However, it's only effective if we take it early. So in order to be able to be like eligible or for Tamiflu to have a good effect for our patients, they have to start taking it within 2 days of symptoms. So it doesn't completely kill the virus, but it reduces the viral spread and replication. So it overall decreases the amount of viral load in our body, meaning that we're not as sick for as long and our body's able to fight off the infection better. Yeah.
So if you can only have it within 2 days of symptoms, will you test positive for the flu with you only having 2 days of symptoms?
You can. Yeah, it just depends on what your current viral load is. So, like, I don't know what the number is or the sensitivity of the swab is, but yeah, you definitely still can. Yeah. It's an oral medication. And so in addition to Tamiflu, so it's great if we can get Tamiflu, if we catch, the potential flu early enough, excellent. But even if in conjunction with Tamiflu, or if maybe we're like 5 days into our symptoms and there's not really a whole lot we can do but just ride it out. Other things we can do is fever management, right? So like Tylenol, antipyretics, pain management. For the achiness, soreness, Tylenol will help with that as well. IV fluids, rest, good nutrition, things like that is what we want to promote with our patients, and other symptom management. Oh, I did forget we were talking about a couple other antivirals. Okay, so our other antivirals we're talking about really for a couple of different reasons. Again, these are separate from our HIV meds, but the other two of note are going to be those that treat like our herpes and our varicella, which is chickenpox. So that's going to be our acyclovir. And then we have like our interferon alpha that treats viral hepatitis, right? So that infection of the liver. With our acyclovir, it can be topical, can be oral, can be IV, and it works by suppressing viral DNA synthesis. And then with our interferon alpha, most of our hepatitis, viral hepatitis, is caused by hepatitis B or C. We can vaccinate and prevent hepatitis C, but there's not a whole lot, hepatitis B, but there's not a whole lot we can do for hepatitis C. So generally we use a combo therapy of some of these antiviral drugs. And they have an effect, again, on the viral replication cycle. And that's all we're going to talk about those. Very, very brief. All right. That's all we have to cover with our antibiotics. Are we feeling okay? Ooh, real quick before we go eat lunch, I meant to do this at the beginning of the class and I forgot. I have a little quiz to like review some stuff from last week, like a little for fun quiz, not a grade quiz. Just let me pull it up for you guys.
Are there any adverse effects of Tamiflu and antivirals?
None that are worth mentioning. All right, let me pull up our quiz. Okay, it's just 5 questions. We'll do this really quick and then we'll break for lunch. I will say, while y'all are getting logged onto the quiz, I really want you to hone in on like the general principles of any antibiotic, right? Regardless of which antibiotic it is, how do we know it's working? What are we gonna do before cultures, right? Those kinds of things. What is a super infection? I want you to hone in on all those things. That patient teaching take the whole 14 days or however long they're prescribed. I want you to hone in on like adverse effects and mechanism of action a lot with our antibiotics, okay? That's what I would really, really focus on.
Unless it's like specific to like the
Yeah,
flu.
I don't care if you, yeah. I mean, like, no, yeah, this one does antivirals or Tamiflu's for the flu, right? Fungizone is for fungal infections, but yeah, I don't expect you to know, like, this treats strep, and this treats pneumonia, and this treats this, you know what I mean?
So we just need to know too, like, okay, this is bactericidal or bacteriostatic, those two.
Yeah, I would know that. Which, if you know the mechanism of action, you'll be able to determine whether it's bactericidal or bacteriostatic. Okay, I think we're missing a couple of people, but I might go ahead and get started because I'm hungry. So if you hadn't logged on, that's okay. You can just do it on your own and read. So this is going to cover last week's content. Is it showing it for you on y'all's screen? Okay. Okay, well, that's fine. We'll do it that way. Don't you know why it's not showing me? Okay, I think we're all almost done, so we'll go over these really quick. Y'all, I swear, feel like I'm generally pretty tech savvy, but this little website, I just must hit something different every time because it never does the exact same thing twice. Okay, so number one, a nurse is assessing a client who's taking levothyroxine or Synthroid. They should recognize that which of the following findings could indicate the patient's receiving too much. Which one is it? Insomnia, yes. How come?
You're gonna start getting the hyperthyroidism.
Yeah, we'll start developing hyperthyroidism symptoms, and all of our other answers are symptoms of what? Yeah, so those would have been correct if I said not enough levothyroxine, right? Number 2, nurse is caring for an adolescent client who has a long history of diabetes mellitus and is being admitted to the emergency department confused, flushed, and with an acetone odor on the breath. Uh-oh. We think they're in DKA. The nurse should anticipate using which of the following types of insulin to treat the client in this acute phase? Regular, yeah. What might they be transitioned to after? Well, they'll be on a regular insulin drip for their DKA for sure. They could potentially be on Lantus afterwards. What would we probably go to right after the regular, though?
The NPH.
Not the MPH, the Novolog. So oftentimes we'll transition to like mealtime subcutaneous, so like the Novolog, the really short acting, so we can do it based off of their pre-prandial blood sugars, pre-meal. But our first acute would be IV regular insulin drip. Number 3, a nurse is performing discharge teaching for a client who has seizures and a new prescription for Dilantin. Which of the following statements by the client indicates a need for further teaching?
I'll be glad when I can stop.
Yes, right? We don't want them to stop taking this medication until we know that either they're not going to have seizures, maybe they had like some kind of acute swelling in the brain that's going to go down and they're not going to be at a seizure risk anymore. But if they have like an epileptic disorder that is non-curable, they're going to need to be on that medication for life. Excellent. Number 4, a nurse is preparing to administer Dilantin IV to a client with seizure disorder. Which of the following actions should the nurse plan to take?
The saline solution.
Yes, the saline solution. Why is it not give the medication at 100 mg per minute?
It's only supposed to be 50.
It's 50, And why don't we dilute it with D5W?
You're just not supposed to.
Because you're not supposed to, yeah. We don't mix it with anything besides normal saline because it's not compatible. And then holding the injection if seizure activity is present, no, we want to continue to give it. It's not going to necessarily stop the acute seizure, right? What class of drugs would do that? Ativan, yeah, your benzodiazepine, right, is for acute active status epilepticus. But we still definitely give our Dilantin. And then last, the nurse is providing teaching to a client who has seizures and a new prescription for Dilantin. Which of the following information should the nurse provide?
Should be A. But it should be the alcohol. Yeah, it should be alcohol.
Yeah, it's the alcohol. Yeah, it doesn't do anything to our urine. We do want them to floss because of the risk of what? Gingival hyperplasia. And then we don't want to do the antacid. Indigestion doesn't really have anything to do with
Which
that.
one is the antacid?
Of the seizure meds?
I'm not thinking of it. Anything.
Okay, that is it. Excellent. So we will take a lunch break. We'll come back at maybe, let's do like 1:05. We'll restart. If you were at the testing center and haven't had a chance to show me your drug cards, make sure you show me your drug cards. But that's it for now. 1:05.
I did the yeah. I said how long does you want to meet with me after class, but if you're willing to wait a couple of hours, I would okay, perfect.
Perfect, thank you.
I showed you my ATI. Yeah, I was gonna ask you. I was like, I didn't check it down, but I was like, did she show it to me or did she not?
I showed it to you. Do you want to see it? No, you're fine. As long as there was so many people, I was just crossing stuff off. I want to make sure.
I know, I saw you crossed out my drug cards, and I was like, I'm just gonna make sure. Yeah, I saw my ATI was there too.
Yes.
Do you think we're gonna be going to full-time school?
No.
And then I don't know.